Thank you very much, everybody, for again starting very promptly this morning. And I hope that you found yesterday's deliberations and discussions informative and useful. I think we had kind of three formats yesterday when you reflect on it in terms of the information to you. Some were presentations themselves by presenters. Some was the fireside discussion that we had, the panel discussion. And then we also had the roundtable discussions that you were able to have at the table, followed by questions and answers for panelists. So again, we are always open to feedback as we move through this process, how we can tweak and change and adjust. But certainly I felt from the feeling in the room and the atmosphere in the room and the chat in the room, it certainly proved to be a really good dialogue and discussion session yesterday. So well done, and thanks to all of you for that. When I reflect back on yesterday, a lot of takeaway messages for all of us, but I think a few things certainly came true for me. And one was an interesting, some messages about why people may take drugs, and then we had some discussion with the panelists around the multiple adversities that some people may face that makes the taking of drugs more extreme and more impactful. There was also some good discussion throughout the day on language from a range of perspectives. One, in terms of the stigmatisation that can emerge for individuals and communities, particularly related to language. And secondly, the issue of language related to a lot of the terminology that's used around legislation, regulation, decriminalisation, reducing harm. And actually just on that one, at some stage this morning, we'll fit in an opportunity for a very brief video just to give a little bit of context around that language, and then we can come back to it again in the next session in a bit more detail. But also one kind of key takeaway message for me from some of the information, particularly from the Health Research Board, was the pervasiveness of drugs and people who will take drugs across ages and across all communities. But equally, while it's pervasive, the harm is particularly concentrated and harmful and hurtful in areas of higher social deprivation for many reasons, not just related to drugs, but they suffer more, and I think that's one thing that came through. So from today, a slight shift in perspective. We're going to have a number of presentations from an international perspective, to give you a perspective from an international, and many of you said to me yesterday evening at the dinner that you'd like to get more information on that. And secondly, from a national perspective, with some of the government departments who set out policy, but also from some of the state agencies involved in the issues related to drugs. So I think we'll get a different perspective again today, and again we'll allow time. I do want to thank you all again, and thank all the presenters from yesterday in terms of time management, because it really means we're not eating into your time in terms of deliberation. So thanks to all of you for being very prompt, and thanks to our presenters from yesterday, which is a nice segue for me to say to our presenters today. I'll remind you and remind everybody just we have to stick strictly to the time that people have been allocated, and we can't eat into anybody else's time. So having said that, now we'll move straight into the first session. And again, we'll have three presenters in this session from an international perspective, and we'll have at the end of that a chance for you to have a discussion at the table, and again some Q&A with the panel. Up on the table here you'll see Owen Quigley, who you've seen in a panel discussion yesterday. And Owen, again, just to remind everybody, is from the European Monitoring Centre for Drugs and Drug Addiction, and Owen will be sharing a perspective from an international perspective as well. Two other presenters who should be on Zoom, if we have them on Zoom, hopefully. Two other presenters, Giovanna Campello, and Giovanna, she's the Chief Prevention, Treatment and Rehabilitation Officer with the, just get the exact title. Yes, Chief Prevention and Treatment and Rehabilitation Officer. And Giovanna will present firstly, but we've also should have online, if we do have online as well, in case Thomas will be online. I'll introduce Thomas Cato separately. So firstly, Giovanna, thank you very much for joining us this morning from the UN Office on Drugs and Crime. And I know everybody's particularly interested in what has been a kind of an international strategy on war on drugs. And I know Giovanna will give us a kind of context about how that has evolved or where we're at now with all of that. So Giovanna, I know you have 15 minutes. Really appreciate that you do stick to time, but we do value your time. I'm conscious you won't be able to stay for the wider panel discussion after you, so you have to move off, but I know you've committed to follow up with any questions and answers that are related to yourself, and we can put them up on our website. So thank you, Giovanna, and over to yourself for the next 15 minutes. Thank you.
Thank you, Mr. Chair, and good morning, everybody, and thank you so much for having us in this amazing democratic process. Let me, while I blabber a little bit, try and share my presentation. And I think you will see that many of the themes that I'm going to present to you are very familiar to you. Just judging from the summary of the discussions that you had yesterday that the chair just did, and let me. Okay, is this moving along? Not moving so much. Okay, it should have moved.
That's good.
Okay, cool. And I pick up from what the chair just said. You know, an international perspective on the war on drugs. You will not find the words war on drugs in an international perspective that is promoted by the United Nations Office on Drugs and Crime. That is because the right to health has been at the center of the drug control system since the very beginning. And what I'm showing to you on the slide is the preamble, the very, very beginning of the first of the 3 drug conventions. That starts the parties concerned with the health and welfare of mankind. And while you might see that the language is a bit old-fashioned, still it's very clear that the member states that signed the conventions at the very beginning were concerned with making certain psychoactive substances available for the medical purposes that they are recognized for. Think just about the management of pain or the treatment of mental health disorder, while at the same time recognizing that the use of these psychoactive substances does pose risks to health and should be controlled. Now, this is what I'm showing to you is the very beginning. The system has evolved. There is a lot of documentation that has been agreed by our member states. And what I will be presenting to you is what comes out from the member states more recently. And I would like to underline this because sometimes what we do is seen a bit stuck in time, like in the 60s and 70s, where the conventions come from. But in reality, has been a lot of evolution. And the other thing that I would like to underline is that what I am presenting is the agreement by consensus of the member states of the United Nations, of course, including the government of Ireland. Is not a policy that the United Nations makes up or I make up because I think it's good in any way. And with this proviso, I have because of the right to health of people is so central to the convention, I have organized my presentation a bit around the right of health to health of different groups of people. And the first one that I would like to remind everybody is the right to health of the people who need access to controlled medicines, to those psychoactive substances that are controlled under the conventions. And I'm taking as an example, particularly the issue of the substances that are needed for the management of pain. And here on the slide, you see some data from our World Drug Report that really take the extreme. North America, where the access is so easy and even too easy, some people would argue, compared to West and Central Africa, where people have no access to the controlled medicines for the management of pain. Now, the member states of the United Nations recognize that a balance is possible. And that is why at UNODC we have a program together with the INCB, the International Narcotics Control Board, and WHO, to promote safe and effective prescription practices with member states. We look at legislation and policy, supply chain management, the capacity of health workers, and also the acceptance of patients, families, and the general public. I will not go into the details, of course, but I'd like to put this on the plate as part of the equation of everything that needs to be thought about when thinking about policies about psychoactive substances, some of which are needed for very recognized medical purposes. Another group of which I would like to give you an idea of what is promoted by UNODC and the member states of the United Nations is the right to health of people vulnerable to starting to use drugs. I think that the chair already alluded to this, that you have discussed this already yesterday, and how there is a wide range of vulnerability factors that are largely outside of the control of the individual. One of the most powerful risk factors is belonging to a family that is dysfunctional or chaotic, and nobody chooses to grow up in such a family. Everybody deals with the situation to the best of their abilities. And these are the kind of factors that make people vulnerable to starting to use drugs and maybe then progressing to drug use disorders. And among all of these, I would like to tease out something that the chair already mentioned, which is the key role of adverse childhood experiences in leading to substance use disorders later in life, and how this, connects and interacts with inequalities, so that we see that adverse childhood experiences do lead to higher levels of substance use disorder later in life, but much more so in the context of marginalized communities, economically marginalized communities. And these are different kinds of data that support this statement of mine. The flip of this is that we do know how to support the healthy and safe development of children and youth through evidence-based prevention. We have made a summary of all the interventions that are effective in preventing drug use and substance use in the international standards that we have published together with WHO. And the great thing is that if we do prevention right, because we are attacking those vulnerabilities, and because those vulnerabilities are at the bottom of many different risky behaviors, we really promote the healthy and safe development of children and youth. And by which I mean that we get less mental health problems, less substance use, of course, but also less risky sexual behaviors, better school performance, and less youth violence, less child maltreatment, and in general, less crime. And we always promote a practice that is based on scientific evidence, so which means interventions that are being shown to be effective and safe according to the scientific evidence, and therefore upheld the principle of doing no harm. I want to go back 1 second between equality, because I'm often told, yes, Giovanna, very nice, but what about people who are in really difficult situations? And I would like to reassure you that the tools that we have found to be effective in evidence-based preventions, including the tools that you see on this slide that have been used and sometimes developed by UNODC itself, have been found to be effective also in very poor communities, very violent communities. They have been found to be effective for both boys and girls. And they have been found to be effective also with in the populations in very difficult circumstances, like refugees, displaced, and otherwise traumatized populations. So evidence-based prevention is not the silver bullet, but we do have tools that address those inequalities and can prevent some of the harms later on. Now, what about the right to health of people who use drugs and people with drug use disorders themselves? Here, I want to give you some, you might have seen that, not giving you much epidemiological data, but I want to give you some data nonetheless. In terms of overall amount of people, I don't have it on this slide, but we know from our colleagues in the World Drug Report that approximately 280 million of people have used a drug in the past year. Fine. What I'm more concerned about is the 38 million of people that with drug use disorders and therefore that need treatment. And this slide, this data that you see on the slide, meaning that globally there is limited access to any drug dependence treatment and care services. Only one of the 8 people that need access to treatment are in treatment. This is a global average. I'm sure that the situation is better in Europe, but there are huge differences regionally, and there are huge differences with specific groups. For example, youth and adolescents. And here on the slides, you see the latest data with regard to women. So, for example, we know that about 1 in 2 amphetamine type user is a woman, but less than 1 in 5 people in treatment for amphetamine is a woman. Women have very much harder access to treatment, and so do people in contact with the criminal justice system and in prison settings, in spite of us having clear evidence that people in contact with the criminal justice system and in prison settings suffer from higher rates of mental health disorders, including drug use disorders, and other also communicable diseases, of course. And this also has a gender dimension in that we know that women who use drugs are disproportionately in prison for drug-related offenses compared to their male counterparts. The final very huge challenge is the issue of poor quality and human rights violation in the name of drug treatment and care. So you remember here, only 1 in 8 people are in treatment. This is just coverage. We don't even know what the quality of this treatment is. And in too many countries still, people who use drugs and people with drug use disorder are subjected to punishment or even human rights violations in the name of treatment and in the name of security as well. Now, the good news is that we do know what to do. It is possible to provide access to quality treatment and care services that are voluntary based on scientific evidence and that are tailored to the needs of populations, especially vulnerable circumstances. Now, let me open a small parenthesis about terminology here. You see here that I say treatment and care, and I don't say treatment and harm reduction. This is because I'm here in an institutional setting, and many of our member states are very hesitant with regard to the term harm reduction. However, the actual intervention that are comprised of under harm reduction and that are aimed at reducing the health and social consequences of drug use and drug use disorders, which I here call care, are very, very clearly recognized and mandated by our member states. Here you can see a document called Treatment of Drug Use Disorder. Let me assure you that this document comprises all of the continuum of care. So from that very first contact with the harm reduction service, needle syringe exchange, Um, and of course, moving into pharmacological treatment, opioid assisted therapy, but also psychosocial therapy and recovery support. So there is the entire continuum indeed. And we have many evidence-based tools that are available. They are here on the slide. I will not talk about them because I will go on too much, but of course they are at the disposal of all of the member states. What I would like to underline is that evidence-based treatment does not only decrease drug use, thus shrinking the illicit market. And remember that I say treatment, but I'm talking about the entire continuum that includes harm reduction and recovery support. But also we have clear evidence that it decreases overdoses,
Giovanna, I'm sorry
crime rates.
Giovanna,
Yes.
I'm sorry to jump in. Can I just ask you in the next minute to any big summary messages you'd like to close?
Yep.
And apologies. Yeah, thank you.
Yes, no problem. It reduces incarceration, prison overcrowding, and associated problems, and it costs less than a probation, incarceration, and doing nothing. And that is why within this our mandates, we really promote the expansion of alternatives to conviction and punishment, including in appropriate cases of minor nature for trafficking. And you can do this at each of the phases of the criminal justice system. And of course, including in prison settings. And I'm concluding with this. I hope I have given you a good overview of all of the provisions the member states have agreed to in order to support the health of humankind as a whole. And I am available to respond to any questions you might have, or more in-depth issues.
Thank you, Giovanna.
Later on.
Thank you very much. I might just say.